A brief outline of our discussion today will include definitions of acute and chronic abdominal pain, the pathophysiologic basis of abdominal pain, and then discussion of acute abdominal pain and chronic abdominal pain separately in terms of etiology, evaluation. First, some definitions. Acute abdominal pain has no real definition, except that it doesn't fit criteria for chronic abdominal pain. In general, acute abdominal pain is short-lived. Chronic abdominal pain has had variable definitions over time. Prior nomenclature included recurrent abdominal pain, which was used for many years, but only referred to pain that was not from an organic cause. The current definition of chronic abdominal pain came out of American Academy of Pediatrics and North American Society of Pediatric Gastroenterology and Nutrition Working Group and the corresponding clinical reports that were published in 2005. Currently, chronic abdominal pain is defined as long-lasting, intermittent or constant abdominal pain that is functional or organic. So the older definition of recurrent abdominal pain is now encompassed in the current definition of chronic abdominal pain, which does not make a distinction between functional and organic etiologies. In older criteria, there was a minimum of 3 months duration to fit criteria for chronic pain. In clinical practice, it's more like 1 to 2 months duration. And again, chronic abdominal pain is subdivided into organic and functional causes. I do want to talk about the pathophysiology of abdominal pain with a focus on the 3 kinds of abdominal pain: visceral, parietal, and referred pain. Visceral pain is sensed by receptors in muscle and the mucosa of hollow organs, serosa, and mesentery, and they respond to stretch. Stretch results in poorly localized pain, and this is because afferent nerves are not myelinated and enter the spinal cord at multiple levels, oftentimes with bilateral symmetric innervation. Visceral pain is dull, crampy, and can result in a burning sensation, but is usually not sharp. In addition, areas in the belly have broad catchment areas. The epigastric region catches pain from the esophagus, stomach, and duodenum, the periumbilical region from the small intestine, and the lower abdomen generally from the large intestine. Additionally, there are some associated autonomic nervous system involvement, and this results in autonomic nervous system associated symptoms like sweating, nausea, vomiting, and anxiety. A classic example of visceral pain is the periumbilical pain in the early stages of acute appendicitis. Parietal pain, on the other hand, has receptors in the parietal peritoneum, muscle, and skin. In addition to responding to stretch, they respond to inflammation and tearing forces. In general, parietal pain is localized, carried along myelinated spinal nerves to dorsal root ganglia. Parietal pain is generally sharp and intense, and movement often makes it worse. A classic example of parietal pain is the focused right lower quadrant pain in later stages of acute appendicitis when the inflammation has reached the parietal peritoneum. Finally, referred pain. Referred pain oftentimes accompanies visceral pain, and it's based on the activation of somatic nerve fibers from a physically distant cutaneous dermatome that happens to share an entry point and/or level to the spinal cord and thus the central nervous system via the same dorsal root ganglion. Examples of referred pain include the right scapular pain that's associated with gallbladder disease like cholecystitis, and mid-back pain that's associated with pancreatitis. We now change the discussion to acute abdominal pain. Acute abdominal pain is a common chief complaint in the primary care setting and in ERs and urgent care. It makes up probably 5% of non-scheduled visits, so-called sick visits. There are some general principles for the provider, whether you're in the outpatient setting or in the ER, and these correspond to important ways to triage patients. It's important to recognize sick patients versus patients that are not sick, and surgical versus non-surgical patients. So what do we need to treat emergently? Well, the things that need to be treated emergently are surgical causes, certain treatable infections, and serious non-GI diseases where abdominal complaints are part of the presentation. It's important to understand outcomes in abdominal pain. So the majority of symptoms are self-limited. Surgery rates are 1 to 10% depending on the study and the setting, and up to 22% of children with acute abdominal pain will have a condition requiring surgery or antibiotics, so specific treatment. However, in real-world clinical practice, 22% is probably an overestimate. Some patients with acute abdominal pain require reevaluation because they have an evolving disease, and some will develop chronic abdominal pain that lasts multiple months. So, when you're in your office or in the emergency room, how do you decide who needs to go to the ER? Who can go home with follow-up on an as-needed basis? And who can go home with close follow-up with serial examinations? And who requires ancillary testing? So, to answer these questions, we really have to understand what are the possible etiologies of abdominal pain. There are many ways to subcategorize acute abdominal pain in children, and location is the way I like to do it because it divides etiologies into distinct and, for me, easy to remember categories that seem to make anatomic sense with a few exceptions. Gender and age of presentation also affect the likelihood of certain etiologies over others, which is not depicted here in this slide. We need to keep in mind also that young children under the age of 5 or 6 are not effective at describing or localizing their pain, particularly visceral pain, and they most frequently point to the periumbilical region when asked about location, and thus these categories on this slide are less reliable in younger children. You can see that the most common causes, like gastroenteritis and constipation and functional disease, are generally experienced as all-over pain by patients, meaning that they have pain all over or can be in multiple different locations. There are etiologies of pain that are specific to location. For instance, right upper quadrant pain includes liver and gallbladder disease and right lower lobe pneumonia. Right lower quadrant pain may point to appendicitis, mesenteric adenitis, Crohn's disease, or pelvic pathology. And left upper quadrant pain, when not due to constipation, may indicate an issue with the spleen, like enlargement, injury, or wandering spleen syndrome. The remainder of the areas are less specific, as colon and small bowel etiologies can really be felt anywhere in the abdomen. So what are the most common causes of acute abdominal pain in children? Well, it depends on the study, but constipation can constitute as much as 48% of acute abdominal pain in the office setting. Other common causes include gastroenteritis, mesenteric adenitis, and all of the etiologies here that I've highlighted in red, including group A strep pharyngitis, systemic viral illnesses, pneumonia, and urinary tract infections. I've colored them in red because they're non-GI etiologies of abdominal pain, but still quite common. In terms of the most common etiologies by study, these are the results from 3 different studies over the last 20 years or so, looking at the etiology of acute abdominal pain in children. The study sizes ranged from 300 patients to about 1,100 patients or so. And the results, as you can see, vary greatly depending on the location where these patients were seen. The table from the left is from a study of patients seen in the primary care setting, in the outpatient office. The study on the bottom right was limited to patients in the emergency room with obvious referral bias, and the study on the top right includes a combination of patients seen in the outpatient setting and in the emergency room. So if you follow constipation here with the blue arrows, it was the final diagnosis in almost 50% of patients evaluated for abdominal pain in the outpatient setting, but only between 2 and 7% of patients when ER patients were included in the study. In contrast, appendicitis, depicted here by the red arrows, was diagnosed in 8% of patients seen in the emergency room, but less than 1% of patients when patients seen in the outpatient world were included in the studies. Other common etiologies common to all 3 studies include viral syndromes, gastroenteritis, and group A strep pharyngitis. What about life-threatening causes? Well, trauma, whether accidental or non-accidental, is important to know. Appendicitis as I mentioned, can happen in up to 8% of patients, can be responsible for up to 8% of abdominal pain in patients being seen in the emergency room. Intussusception, so more classic intussusception, ileocolic intussusception without necessarily a lead point in the younger age group, or in the older age group where a lead point is more likely to exist. Intestinal malrotation with volvulus, a condition that's typically picked up in infancy, but that we see also in in school-age children as well as in adolescents and older children. Adhesions with small bowel obstruction, particularly if there's been prior surgery. Incarcerated inguinal hernias. And then necrotizing enterocolitis and Hirschsprung's disease and associated enterocolitis, which are more commonly diseases of the newborn, and I put in blue here because they're age-dependent, although Hirschsprung's disease can be diagnosed later in life. And then ectopic pregnancy and diabetic ketoacidosis, life-threatening causes that I've highlighted here in red because they're of non-GI origin. What about non-gastrointestinal causes of acute abdominal pain? Well, there are infectious causes like group A strep pharyngitis, systemic viral illnesses like influenza and others, pneumonia, particularly in the lower lobes, and urinary tract infections, simple infections like cystitis, or more complicated infections like pyelonephritis. There are gynecologic etiologies. Ectopic or intrauterine pregnancy can cause acute abdominal pain, as can pelvic inflammatory disease. And of course, ovarian pathology like cysts or ovarian torsion. In young males, testicular torsion can cause abdominal pain. Diabetic ketoacidosis, vasculitis with effect on the GI tract, including Henlock-Schönlein purpura or HSP, kidney disease, particularly nephrolithiasis, and then systemic conditions like familial Mediterranean fever, hereditary angioedema, and acute intermittent porphyrias. This is a triage algorithm for children with acute abdominal pain, with a focus on the outpatient setting. Here, the first triage question is there a concern for life-threatening condition, or is the patient unstable? If the answer to either of those questions is yes, then it's prudent to refer the patient to the emergency room for evaluation. If the answer is no, the second question is, do you suspect a treatable infection? If the answer is yes, look for that infection and treat accordingly based on results. If the answer is no, do you suspect another treatable etiology? If the answer is yes to that question, then you would test for that etiology and treat accordingly with interval follow-up. If the answer is no, the fourth question is, do you suspect a self-limited illness, like a viral infection? If the answer is yes, follow-up can probably be as needed. If the answer is no, it's probably prudent to schedule a formal follow-up so that you can reassess the abdomen in a time interval. How do we use our history, physical examination, and ancillary tests to determine how to categorize risk? Well, on history, we can use quality of the pain, location of the pain, and frequency and exacerbating factors. For instance, right upper quadrant pain, we think about the liver and the gallbladder. Quality of pain, colicky pain in the textbooks is consistent with intussusception, amongst other conditions. Pain frequency, and then of course exacerbating factors. Does food make the abdominal pain worse? Does movement make the abdominal pain worse? What makes the pain better? In addition, has there been recent travel or sick contacts with similar conditions or potential infectious disease that could have been contracted? Are there associated symptoms such as fever, vomiting, diarrhea, or dysuria or hematuria? Vomiting that's bilious is a bowel obstruction until proven otherwise. It's important to note whether diarrhea has been bloody or not. Bloody diarrhea would make you more concerned about an infectious colitis or an inflammatory bowel disease. If the diarrhea is not, you're less suspicious of those. Past medical and past surgical history is also important, particularly with the history of prior abdominal surgery, as this can lead to adhesions and small bowel obstruction. How about on the examination? Well, vital signs here truly are vital. They are appropriately named. and general appearance is of utmost importance, especially in young children, where your abdominal exam may be limited, secondary to the child's fear of medical providers. You can learn quite a bit from general appearance and vital signs from across the room. If you do get to perform a good abdominal examination, you want to do so in a cooperative and quiet child. Oftentimes this means performing the examination where the patient is most comfortable, and this might mean on the parent's lap. When you do examine the abdomen, you want to check for distension, which can signify obstruction. You also want to assess the bowel sound frequency and pitch. If there's a lack of bowel sounds, you could be worried about an ileus or an obstruction. You also want to assess for tenderness. Reproducible tenderness is more likely organic. Focal tenderness is also more consistent with an organic disease as opposed to diffuse tenderness in the belly. Percussion, tenderness, rebound, and guarding also are more likely to signify peritoneal inflammation and peritonitis. A perianal and digital rectal exam can be very enlightening. A perianal exam itself can reveal skin tags, fissures, or fistula that might make you concerned about inflammatory bowel disease. And a digital rectal exam can show hard stool in the rectal vault, which is consistent with constipation, occult blood, where you'd be concerned about GI blood loss and would point you in the direction of an organic cause, and then adnexal tenderness in females, signifying gynecologic pathology. There are other maneuvers to elicit peritonitis in patients with appendicitis and other diseases that cause peritonitis, including having the patient jump off the bed and see if that elicits pain, and also the Rovsing signs, obturator, and Psoas signs. Again, serial abdominal examinations are important because some conditions evolve over time. Finally, on examination, you want to do a fairly full exam to assess for non-GI causes. You want to look at the skin for evidence of jaundice or rash, which can be evident in liver disease or in Henoch-Schönlein purpura or other conditions. You want to do a good oropharyngeal and head and neck exam, looking specifically for pharyngitis and any cervical lymphadenopathy that might point you in the direction of group A strep. You want to do a testicular exam in boys to make sure that there's no torsion or hernia. You also want to do a gynecologic exam if indicated in females. And finally, and perhaps most importantly, you want to examine the lungs because, as mentioned before, lower lobe pneumonias are a frequent cause of abdominal pain in children, and particularly in young children. So what about diagnostics and ancillary tests? Well, they're not to be used in everyone with acute abdominal pain. What are the indications? Well, if your patient is sick, you should do some more diagnostics. And if there's no improvement after recurrent evaluation in a patient, it's probably also prudent to do so. Additionally, if your suspicion is high for a treatable infection, like group A strep pharyngitis or urinary tract infection, then it's reasonable to test for those things and treat accordingly. And in postpubertal females, you want to have a low threshold for acquiring pregnancy testing. Labs include blood and serum, urine and stool tests, and then finally imaging tests including plain film, ultrasound, and cross-sectional imaging like CAT scan and MRI. This table is from a 1996 study published in Pediatrics showing that out of 1,000 patients, there were 24 patients that had been initially evaluated for acute abdominal pain that had their diagnosis changed after reevaluation within 10 days. About 2/3 of these new diagnoses required timely, specific treatment, be it surgery for appendicitis in a couple of the cases, or antibiotics for treatable infections like pneumonia. The most consistent finding at the initial visit for these patients was the presence of fever. And I'm including this slide really to highlight the importance of discharge instructions and communication with the family and patient, and reasons for reevaluation and their return to care. So no discussion of acute abdominal pain in children would be complete without a discussion of the elephant in the room, which is acute appendicitis. Acute appendicitis remains the most common reason for emergent abdominal surgery in children. It is more common in older children, occurring with 20 to 30 cases occurring in 10,000 patients per year. It is less common in younger children, but younger children represent a diagnostic conundrum. It's a much more challenging diagnosis in younger children, specifically in children less than 5, for a number of reasons. And this is exemplified by higher perforation rates at the time of diagnosis, which probably signifies a diagnostic delay, but also higher negative appendectomy rates at the time of surgery. Here, it is a balance. If we want lower negative appendectomy rates, it's likely going to result in higher perforation rates and vice versa. So we're just not as good in young children at deciding which children need to go to the OR and when. How does acute appendicitis present? Well, there's age variation. The textbook presentation is that of fever, anorexia, vomiting, and periumbilical pain that migrates then to the right lower quadrant. This is the most common presentation in older children and adults, but the younger child is less likely to exhibit classic symptoms. They are more likely to have diarrhea than older children and adults are, and in younger children, pain is less likely to be localized in the right lower quadrant. Additionally, since there is more perforation at the time of presentation, more young children have guarding and other peritoneal signs at the time of diagnosis. Physical examination. Well, fever has the highest predictive value. Tenderness and peritoneal signs are less predictive, particularly guarding, rebound tenderness, percussive pain, and abdominal wall rigidity. As mentioned earlier, a cough or hop test can elicit pain with movement, of the abdominal wall, and this would be suspicious for peritonitis. A digital rectal exam is usually not helpful in the evaluation and diagnosis of appendicitis. How about labs and diagnostic testing? So labs for appendicitis should never be used alone. But a CBC with a differential showing leukocytosis and prominence of immature white blood cells have a sensitivity and specificity ranging from 70 to 90%, depending on cutoffs and the study. A CRP has a lower sensitivity and specificity than white blood cell count and ANC and doesn't seem to add much to the diagnosis. Imaging, again, should not be performed in everybody, but when it is, typically it's with ultrasound or CAT scan or a combination of the two if ultrasound does not identify an appendix. For high-risk patients, you definitely want to consult the surgeon first because that surgeon may choose to take the patient to the operating room and obviate the need for imaging. Low-risk patients, when the labs are normal, are unlikely to need imaging either. It's really these intermediate-risk patients that are the group most likely to be imaged. And I've just included this chart to show you the frequency of atypical findings in children with proven appendicitis with median age of 12. Of note, 40% of patients had no anorexia and 50% had no migration of pain. And as I already mentioned, classical physical examination findings perform less well, with an absence of fever in 83% of subjects, and 47% of subjects were without guarding, and nearly 70% of them had a negative Rovsing sign. However, although not sensitive for appendicitis, the presence of decreased bowel sounds and a positive Rovsing sign, which are not shown here in this table, had the highest likelihood ratio in predicting appendicitis in patients with abdominal pain in this study. So I'm going to shift gears to begin speaking about chronic abdominal pain. Chronic abdominal pain is defined, again, as long-lasting, intermittent, or constant abdominal pain that is functional or organic in etiology. Again, this is the definition set forth by a working group from the American Academy of Pediatrics and the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition in 2005. Again, in clinical practice, duration of 1 to 2 months really fits clinical criteria for chronic pain, and functional pain is far more common than organic pain, probably in a 3 or 4 to 1 ratio. Chronic abdominal pain can be divided into functional abdominal pain and organic causes. Organic causes are further subdivided into organic GI causes and organic non-GI causes. And functional abdominal pain is divided into functional abdominal pain syndromes that are categorized by Rome 3 criteria. So what's the epidemiology of chronic abdominal pain in children? Well, there's a wide range in prevalence, from 0.5 to 19% of children from Western countries. Before puberty, there's an equal representation of males and females, but after puberty, there's a female predominance, 1.4 to 1. It occurs in all ages of children, and there's inconsistent data on peaks, the timing of peaks. Chronic abdominal pain represents 2 to 4% of visits to primary care pediatricians and almost 50% of visits to pediatric gastroenterologists. And although we don't know an exact cost to the healthcare system, if we extrapolate data from adult irritable bowel syndrome data, which is a functional abdominal syndrome in adults, it likely costs the medical system billions. So let me just briefly discuss with you the most common organic GI causes for chronic abdominal pain. This list includes acid peptic disease, constipation, carbohydrate malabsorption, celiac disease, infectious etiologies, and particularly parasitic diseases, which are more likely to last longer than viruses or bacteria, inflammatory bowel disease, and pancreatitis, not acute, but acute recurrent pancreatitis or chronic pancreatitis. Less common GI etiologies of chronic abdominal pain in children include gallbladder disease, eosinophilic GI disease, chronic hepatitis, surgical causes like hernia and chronic appendicitis, foreign body and Bezors, and intestinal malrotation. Non-GI causes of organic non-GI causes of chronic abdominal pain include recurrent urinary tract infection, abdominal wall pain that's attributable to musculoskeletal phenomenon, gynecologic conditions like dysmenorrhea, endometriosis, and pelvic inflammatory disease, and nephrolithiasis. Less common non-GI causes include UPJ obstruction, abdominal vasculitis like HSP, hereditary angioedema, acute intermittent porphyrias, familial Mediterranean fever, and collagen vascular disease. And finally, functional abdominal pain disorders, again defined by Rome 3 criteria, help define 5 distinct disorders: IBS, or irritable bowel syndrome, childhood functional abdominal pain, childhood functional abdominal pain disorder, functional dyspepsia, and abdominal migraine. More on these later. So how do we distinguish organic from functional? Because this is of utmost importance. Well, to be honest with you, location of pain, severity of pain, frequency of pain, and effects on lifestyle are pretty much completely unhelpful in this regard. Associated symptoms and your abdominal examination are minimally helpful. So what is helpful? Well, we can start to distinguish organic pain from functional pain by the presence or absence of these alarm signs and symptoms. The presence of alarm symptoms and/or signs make it more likely that the child has an organic etiology, and this increase in pretest probability can help justify further diagnostics in a select group of patients to search for that organic disease. The list includes, but is not limited to, gastrointestinal alarm symptoms and signs like nocturnal symptoms, and that definition means waking from sleep with pain, GI bleeding or blood loss, severe chronic diarrhea, significant vomiting, which is recurrent, persistent localized right upper quadrant pain, persistent localized right lower quadrant pain, dysphagia, and perianal disease, including tags and fissures. Systemic signs and symptoms, as well as issues with family history, include unintentional weight loss, poor linear growth or decelerated linear growth, delayed puberty, unexplained fever, joint pain and swelling, recurrent oral ulceration, unexplained rashes, and a family history of inflammatory bowel disease. So what do you do next? Well, after you've collected and taken your history and you find your patient has no alarm signs or symptoms, well, you still need to consider testing stool for occult blood. Because if there is occult blood, this points in the direction of an organic disorder. If there's not occult blood, then really reassurance and close follow-up are the name of the game. This is for a variety of reasons, but additional labs and imaging are unlikely to change the prognosis or increase the yield of finding an organic cause for chronic abdominal pain when no alarm signs and symptoms are present. And there's currently a debate about whether additional testing is helpful for families or more harmful. On one hand, it can reassure a very nervous family. On the other hand, negative testing can reinforce fears that there may be an organic disease that you've just not identified yet. In my practice, once I've ruled out alarm symptoms and signs, I introduce the potential contribution of psychosocial factors early in my relationship with the patient. This is a challenging thing. And to be honest, telling a patient that you're not going to do any more workup is far more time and labor intensive than ordering tests that you know are likely to be unhelpful. If you do end up ordering more testing to reassure a nervous family, a discussion about their response to normal results should happen prior to testing, as well as the start of a discussion about functional abdominal pain itself and what that might mean for the patient and their family. In terms of therapeutic trials, there are minimal risk empiric therapeutic trials which are reasonable to try. For instance, peppermint oil, which has reasonable data that it may improve irritable bowel syndrome in children. Dietary changes like increasing fiber and restriction diets like lactose-free, dairy-free, gluten-free, and more recently the low FODMAP diet. The data on these diets in childhood functional GI disorders is inconclusive. Acid blockade medications like H2RAs and proton pump inhibitors, the data is also inconclusive for their effect on functional GI disorders, apart from potential benefit in functional dyspepsia. So what if your patient does have alarm signs and symptoms? What test do you order? Well, as always, it depends on what you're looking for. Labs are a reasonable good screen. Blood and serum that I usually obtain in this setting are a complete blood count, a metabolic panel, liver function tests, amylase and lipase if indicated, inflammatory markers like ESR, CRP, celiac serology, and thyroid testing. Urinalysis is quick and cheap and may pick up occult urinary tract infection, which is fairly common in chronic abdominal pain. And in women of childbearing age, again, you're going to have a low threshold for pregnancy testing. I already mentioned stool fecal occult blood testing. If there's diarrhea, you may want to send studies for infectious enteritis, and you also may want to send H. pylori antigen if indicated. Beyond lab work, what else could be next? Well, breath testing. There are two different types of breath tests that we often use in the gastroenterology office. The first is hydrogen breath testing for carbohydrate malabsorption, the most common of which is lactose intolerance, and also urea breath testing for H. pylori infection when your suspicion of H. pylori is high and stool testing is not available. Beyond breath testing, there's imaging, plain X-ray, ultrasound, and again, cross-sectional imaging like CAT scan and MRI. And finally, endoscopy and pH monitoring. These are performed by a gastroenterologist. So let me shift the discussion in more detail about organic chronic abdominal pain. I already showed you this slide, but I would like to go into more detail on the four diseases that are in red: acid peptic disease, constipation, carbohydrate malabsorption, and inflammatory bowel disease. And this is because these are really common. So acid peptic disease includes inflammation in the esophagus, stomach, duodenum, and frank ulcers that are peptic related in the stomach or small intestine. Symptoms of acid peptic disease are generally dyspepsia and are very similar to those of a functional gastrointestinal disorder called functional dyspepsia, so it's difficult to distinguish between the two. There are diagnostic clues of acid peptic disease, and these include location, keeping in mind that this is more attributable in older children. Older children will generally have epigastric pain with acid peptic disease. Also, relationship to meals. So symptoms peak 2 to 4 hours after a meal. Nocturnal symptoms between 11 and 2 a.m. may be a result of the circadian acid production when the circadian acid production is at its highest. And if there's improvement with alkali agents and acid blockade, this would also be suspicious for acid peptic disease. So if you make a diagnosis, how do you treat it? Well, you treat it with lifestyle modifications, watching the diet, weight loss, and acid-blocking medications like histamine 2 receptor antagonists and proton pump inhibitors. If a gastroenterologist has identified inflammation in the upper GI tract, proton pump inhibitors are superior to H2RAs at healing the mucosa. Constipation. So constipation is a very common chief complaint in pediatrics and pediatric gastroenterology. Diagnostic clues include hard, small stools, large caliber stools, low stool frequency associated with straining, fecal incontinence, which is oftentimes due to overflow from a large rectal stool mass, and physical exam findings like mass on exam, abdominal fullness, and hard stool in the rectal vault on a digital rectal exam. Treatment is oftentimes empiric and includes diet changes like increasing fiber and fluid and limiting dairy, as well as lifestyle changes like increasing the activity level. And finally, pharmacotherapy, including osmotic and stimulant laxatives. Carbohydrate malabsorption, the most common of which is lactose malabsorption or intolerance. Rates of lactose malabsorption range from 10 to 90+% depending on your ethnic background. And there's very high rates in people of Asian and African background and Native Americans. Diagnostic clues to carbohydrate malabsorption, and specifically with lactose malabsorption, are bloating, nausea, crampy abdominal pain, and oftentimes diarrhea after lactose ingestion. Here, there is a large overlap with diarrhea variant irritable bowel syndrome, which can also respond to lactose restriction. Other diagnostic clues include a response to an empiric trial of dietary restriction and breath hydrogen testing for lactose intolerance. Treatment includes lactose restriction and/or lactase enzyme replacement. And when you do lactose restriction and/or dairy restriction, you need to assure that there's caloric and vitamin mineral substitutes, specifically protein and fat calories, as well as calcium and vitamin D replacement, which is so important for bone health in children. Moving on to inflammatory bowel disease. Inflammatory bowel disease is made up of two distinct disorders that are related but certainly not the same. Ulcerative colitis, which is a condition limited to the colon and starts at the rectum without skip lesions, as well as Crohn's disease, which is a disease that can affect anywhere in the GI tract from mouth to anus, and oftentimes includes skip lesions with areas of the bowel that are inflamed, bordering areas that are normal. The inflammation in ulcerative colitis is mucosal only, whereas the inflammation in Crohn's disease can be transmural, leading to complications such as fibrostenotic disease and penetrating disease leading to intra-abdominal abscess and fistula. About 10% of the time in children, we can't tell which one a child has, and we group these patients into an indeterminate colitis or IBD-U category. About 55% of kids with IBD have Crohn's, and about 1/3 have ulcerative colitis, with the remaining patients in the indeterminate colitis category. IBD in general affects about 1.5 million Americans, and it's estimated that 20 to 25% of those are diagnosed during childhood before their 18th birthday. The incidence of IBD is rising, and particularly in developing nations. And the etiology of IBD is multifactorial and includes genetics, environment, and immune dysregulation, just like any autoimmune disease. There are some special issues in children. The first is nutritional status and how that affects linear growth. If inflammatory bowel disease is not treated aggressively in children and the inflammation is not dealt with, this leads to stunting. There's also pubertal delay, as well as psychosocial functioning. And what we want to avoid is a delay in diagnosis, particularly at such an important phase for growth. So how do we do that? Well, how do we screen for inflammatory bowel disease? There's clinical history clues, and these include rectal bleeding and chronic diarrhea, which can be bloody or non-bloody, as well as extraintestinal manifestations like fevers, joint pain or swelling, typically migratory, oral apathy that are recurrent, and unusual rashes, like erythema nodosum and pyoderma gangrenosum. There are clues on physical examination, like weight and height trends, and here it is of vital importance to look at growth charts. Additionally, on physical examination, the perianal examination is quite important. If this reveals any signs of perianal disease, like fissure, deep fissures, or fistula, this would be suspicious for inflammatory bowel disease. Lab screens like a sedimentation rate, a C-reactive protein, platelets, white blood cell count, hematocrit, and albumin are abnormal in only about 70 to 75% of pediatric IBD patients at diagnosis. So they're helpful, but certainly not completely reliable. We also have stool tests like fecal occult blood testing. If there's diarrhea, you want to evaluate for an infectious enteritis or colitis for two reasons. One is to make sure they don't have an infectious etiology, and the second, to make sure it's negative so that you can make your diagnosis of inflammatory bowel disease. And then newer tests like fecal calprotectin and lactoferrin, which are inflammatory markers that are elevated in cases of inflammation in the gastrointestinal tract. To date, inflammatory bowel disease remains a tissue diagnosis done with mucosal biopsy through endoscopy and colonoscopy, and then supported by imaging, particularly of the small bowel in places where, mid-small bowel in places where an endoscopy and colonoscopy can't reach. Treatment is through the gastroenterologist, but immunosuppression continues to be a mainstay of therapy for Crohn's disease and ulcerative colitis. So now moving on to functional abdominal pain. So this slide depicts the proposed etiology of functional abdominal pain. Here, there is a complex interplay of biologic and psychosocial factors, and the triggers are currently unknown. But there's some evidence that more functional gastrointestinal disorders occur in people that have had pyloric stenosis or cow's milk protein allergy or Henlock-Schönlein purpura early in life. What are the other triggers? Infections, antibiotics, diet, we just don't know yet. But this is what happens, or this is what we think happens. There's an early life event or trigger which causes sensitization of spinal nerves and sensory neurons and altered stress response. This in turn develops a modified relationship between the enteric nervous system and the central nervous system, the so-called brain-gut axis. This is also affected by psychosocial factors, which also affect motility in terms of contraction and bowel distension. And together that leads to visceral hyperalgesia and exaggerated response to stimuli, which results in pain and discomfort. Again, functional abdominal pain disorders are divided into 5 distinct syndromes: irritable bowel syndrome, childhood functional abdominal pain, childhood functional abdominal pain disorder, functional dyspepsia, and abdominal migraine. These functional gastrointestinal diseases share quite a bit of features. They share frequency for criteria, once per week for at least 2 months duration. They all involve pain or discomfort, unlike other functional gastrointestinal disorders like like functional constipation, which does not require pain as a criteria. There's also no evidence of organic disease, and specifically an inflammatory, anatomic, metabolic, or neoplastic process that might be leading to pain. There are also some features that are unique to each individual functional gastrointestinal disorder that's associated with pain. Location of pain, for example. Pain in the upper abdomen is more consistent with functional dyspepsia. If there's a relationship to defecation, changing in stool frequency or consistency, this is more consistent with IBS. There's pattern is a unique feature as well. Paroxysmal pain with return to baseline in between is most consistent with abdominal migraine. And then associated symptoms like headache, nausea, vomiting, photophobia oftentimes accompany abdominal migraine, and then somatic issues like sleep issues and limb pain often accompany childhood functional pain syndrome. In terms of level of dysfunction, for example, to qualify for childhood chronic abdominal pain syndrome or disorder, there needs to be symptoms 25% of the time and some loss in daily function. So let's talk about psychosocial issues in functional gastrointestinal disorders. So the following are increased in children with functional GI disorders compared to unaffected children. There is more anxiety, more depressive symptoms. There have been more negative life events. There is more stress. And there are more emotional and psychiatric disorders later in life. Additionally, parents of children with functional GI disorders have more anxiety, depression, and somatization. It's also equally clear that the following are not increased in children with functional gastrointestinal disorders compared to controls, and that includes conduct disorder and oppositional behavior disorder. So what are our treatment goals and the general treatment principles for functional gastrointestinal disorders? The first is to reduce pain and the associated symptoms. You have to set realistic expectations with patients and their families. I can never guarantee a family that their pain is going to go away, and I say this at the outset. My second goal for families is to return to function, and this is not only for the patient, but also for the family as a whole. We oftentimes use a multidisciplinary team, including the primary care physician, gastroenterologist, psychotherapist, and psychopharmacologist if needed. Patients and parents are an integral part of this multidisciplinary team as well. Patient and family education is vital in this setting. You cannot, as a provider, minimize symptoms, and you need to provide repeated reassurance that there is nothing organic going on. And providing mechanistic information, when we have it, for functional GI disorders validates symptoms and fosters trust and may actually improve outcomes for the patient because of an improved therapeutic relationship with their physician. Other tenets of care for functional gastrointestinal disorders: eliminate triggers, whether those be dietary triggers or stress. Improve tolerance and coping mechanisms, and I'm going to talk about that more in a second. And really important to normalize life as much as possible. Get them back to school if they're out. Stop the sick roll, and that includes counseling for the whole family and the child. How do we improve tolerance? So if we can't guarantee the pain's going to go away, how do we make children more tolerant of that pain? Well, it can be done with relaxation techniques like deep breathing and yoga and regular exercise, as well as with guided imagery, biofeedback, distraction. I'm a big proponent of keeping kids as busy as possible during this time, as well as cognitive behavioral therapy, which is proven to improve outcomes, at least in the short term, in functional GI disorders. What about some symptom-specific treatments? So what about for pain with functional gastrointestinal disorders? Well, probiotics were supported by a 2014 meta-analysis to improve pain in functional GI disorders in children. With fiber, there's mixed data. So there's a negative systematic review that was from 2009, and there are some side effects from fiber which include bloating, so I'm not a big proponent of that. Peppermint oil. So perhaps the best supporting data is with peppermint oil. However, too much peppermint oil can lead to gastroesophageal reflux symptoms as well as kidney side effects. We oftentimes use antispasmodic medications in GI for their anticholinergic properties. And really, we're doing this with very limited data. Tricyclic antidepressants, well, they're commonly used, but there was a negative systematic review that came out in the last 5 years or so. Despite this, we regularly use these medications. They can also benefit the patient in that they can regulate sleep and also treat any comorbid depression. SSRIs and other newer psychotropic medications have not been formally studied well enough to make a judgment, so there's really limited data right now. How about dyspepsia? Well, avoiding food triggers, including foods that bloat and acidic foods, eating smaller frequent meals, and then, as I mentioned before, this is the one indication potentially for acid blockade, or at least a trial of acid blockade with functional dyspepsia. What about natural history and prognosis? Well, most kids with functional gastrointestinal disorders get better. About 70%. In one study, were symptom-free at a median follow-up of 5 years. However, that means 30% didn't get better. And the truth is that some don't. Additionally, it seems like functional GI disorders in childhood seem to predispose to development of irritable bowel syndrome later in life. And most recently, it's been shown that functional GI disorders in childhood increase the risk for emotional and psychiatric disorders later in life. The best data for this is from a 2013 large cross-sectional study showing odds ratios of 4.9 and 3.57 for lifetime and current anxiety disorders, respectively, in young adults with functional GI disorders compared to controls who did not have functional GI disorders. Are there predictors of persistent symptoms in this setting? Well, if you have a parent with GI symptoms, then you are more likely to have persistent chronic abdominal pain in childhood, and this has been supported by a systematic review. Other variables have not been supported by systematic reviews, but have been supported by individual studies, and this includes lack of insight into psychosocial contribution on the part of the family, female gender, younger age at diagnosis, comorbid depression or anxiety, and longer duration of pain, and many negative life events. So in conclusion, acute abdominal pain is common in children. Most acute abdominal pain is short in duration and does not require specific treatment. It's important to recognize signs of life-threatening and readily treatable causes. Reevaluation is often important and probably underused. Chronic abdominal pain in children is also common, and the cause is functional far more often than it is organic in etiology. It is important to recognize alarm signs and symptoms, and the presence of such alarm symptoms should prompt further diagnostic evaluation for underlying organic disease. The treatment of functional abdominal pain should be via a multidisciplinary